Rotate your phone. You can't turn your phone while recording. Ah.
Are you turning your phone?
I don't want to turn my phone. I want to be in this mode. We're live anyway, Rob. So
I'm just like worried if you don't know how to function with this camera.
I certainly don't.
Hope you're
Hey Rob, good morning.
Good morning.
Thank you for doing this.
You're welcome.
I'm still struggling with the rotational aspect. Sometimes I get it right, sometimes I don't.
You know what? That's life.
So Dr. Shaffer is a
gastroenterologist.
Thank you.
Yes.
That's a lot. And what I'm trying to show are these tools that you have.
Lots of tools.
They look like these. They look like snakes. They're big snakes.
Yeah, but they're
Go ahead and pick one up and show it to me.
Well, let me put on some gloves.
Okay.
They're gonna be sterile or semi-sterile.
Oh, you're gonna get in the shot. She's in the shot. Okay.
She's a movie star. Doing her thing. What we do. What do you want to know about the scope, Brad?
I just want you to show it to.
Why don't we do a live colonoscopy on you?
Maybe one day. Maybe one day.
That's the way it's going.
I probably need one. In fact, who needs a colonoscopy?
So, interestingly, the guidelines have just changed. So they changed the guidelines to age 45. It used to be age 40. But before I scare everybody with this, you are sedated when we do a colonoscopy. This looks very long. And you would think, does this entire scope go into my colon? Your colon is actually this long.
So that entire thing goes into the colon.
Well, it does for a short period of time. But we do what is called a reduction. So as we put the scope in, we also take the scope out. So unlike most people think, oh, a colonoscopy is just sticking a scope in and pushing it to the end of the colon. The colon is not in a straight line. It goes up and down and around and twists and turns. And depending on how much surgery you've had, it takes a very skilled endoscopist, of which I am, to go exactly where you need to go.
Right.
So usually in the end, you're only having about this much scope in the colon. In fact, your colon is about 6 feet long, but that's about how much we have in. Because the scope is looped and the colon goes back over the scope, telescopes, as you pull it out. And we don't really look much when we go in because it's not really important, but as we come out, we look very carefully behind every single fold. And you can move this tip, as you can see. Move it back, forward, left, and right.
What are you looking for? We're
looking for polyps. And we're looking for AVMs, and we're looking for Crohn's disease. And
AVM?
AVM.
AVMs.
So those are vascular ectasias that can grow in the colon, and that's one of the causes for anemia. But mainly we're looking for polyps.
So when you're 45, and you're asymptomatic, you need a scope to make sure that
you don't develop colon cancer.
That you don't develop colon cancer.
If
now,
you find the polyps early, then you can take them out. If you take them out early, then you can prevent colon cancer. Now, polyps grow really, really slow. So typically, polyp takes about 10 years to become a colon cancer. So it starts out really small, kind of like a small little wart, and then it grows and it grows, and then it gets bigger and bigger. It develops cancer in the tip. The cancer burrows down to the colon, and once it gets in the colon lymphatic system, it can spread anywhere and everywhere. You want to get to us before that.
So, what kind of? That's for asymptomatic people, right?
That's right.
But what about if you're? What kind of symptoms would somebody
expect for colon cancer?
Well, just expect in general that might lead you to do a colonoscopy.
Well, the indications for colonoscopy are pretty wide and broad. So, we look for alarm symptoms. So, the change in bowel habits. So, if you went from having no bowel movements every 7 days to having multiple bowel movements every day, or if you went from having multiple bowel movements every day to having no bowel movements but every 7 days, that's considered a change in bowel habits. So, people define like constipation as being different, right? So, they said, I was one way. Now another way. So depending on where they were before, there's a significant change. That's considered an alarm symptom. It's not constipation if you've gone to the bathroom once a week for your entire life and you're comfortable with that and you have no problem. But for some people who went every day and now they're going once a week, that's a significant problem. That's considered a change. Rectal bleeding, always a problem. Some people know they have hemorrhoids. Any woman who's had a child knows that you get hemorrhoids after you have childbirth. That's very common, so you're going to get some rectal bleeding there. Of course, any kind of nocturnal bowel movement, so if you're waking up in the middle of the night going to the bathroom, that's always a problem. So we're concerned about that. And there's a number of other reasons, abdominal pain, et cetera, et cetera.
Okay. What about going the other way?
So endoscopy?
Yes.
Endoscopy also has a lot of indications, but typically speaking, we're looking for ulcers. We're looking for people who have maybe pyloric stenosis, people who have nausea and vomiting, We're looking for celiac disease as confirmatory diagnosis. So all kinds of reasons we do upper endoscopy.
So ulcers, how do ulcers present to you typically?
They present with usually boring epigastric pain, but they can present with back pain, right upper quadrant, left upper quadrant. And usually it's better after you eat, depending on where they are. And then it's worse after you have about a 30-minute period and they start aching, kind of burning. Take antacids, they feel better, and then it comes right back again.
Can it be positional?
No, not typically. It's not
Okay.
positional at all. So, antacids will help it. Sometimes they start developing dark stool, and that's usually when the ulcer's gotten deep enough that it bleeds. And when it bleeds, of course, that's a big problem. So they have to come in pretty quickly for that.
And can people do anything on their own other than take antacids, or?
Well, proton pump inhibitors, but that's the reason it says on the box that proton pump inhibitors you buy don't use more than 14 days at a time without consulting your doctor. Because at that time, if you still have a problem, it's not just, hey man, I ate too many burritos and drank too much beer. It's, hey, I got a big problem, so I need to go see my doctor.
All right, I promised one of the nurses who was watching my show with Dr. Heinzman on hemorrhoids that I did not cover more medical management. I just
like non-surgical management of hemorrhoids.
Exactly.
Okay. So hemorrhoids are a big problem. So there are different kinds of hemorrhoids. Obviously, they're internal and external hemorrhoids. You would know if you have a hemorrhoidal problem if you have a thrombosed hemorrhoid because you will not be able to sit down. It is extraordinarily painful. So it's like somebody sticking a cattle prod somewhere it doesn't belong and pulling the trigger over and over and over again. You might notice some bleeding, but most of the time when it initially starts, you'll just notice a swelling that will occur right on the outside tip of the anal opening. So that'll get progressively bigger and bigger and bigger until it becomes so painful that you have to go somewhere and do something.
Right.
The treatment for that is surgical. So that's when you would see Dr. Heinzman and he would lance the hemorrhoid, take the clot out, and you would feel extraordinarily well after that.
Correct.
And it heals up on its own.
Right.
But for medical treatment, what we typically do, if it's an external hemorrhoid, we use creams and some numbing agents and things like that. Tell people to eat a high fiber diet so they don't have any kind of constipation that causes the hemorrhoid to start with to get irritated. But there's not a whole lot you can do for external hemorrhoids. We treat more on the internal hemorrhoids from an endoscopy side. So internal hemorrhoid treatments, we do a flexible sigmoidoscopy. If you've had a colonoscopy, if you haven't had a colonoscopy, you get full colonoscopy, and we look at it at the time, and we can retroflex that scope like I showed you how it turned.
Yeah.
Put up in the rectum, we retroflex it and look down, you can see that whole complex of internal hemorrhoids. If they're grade 3, which means they're fairly big, then we can do something called IRC. And IRC looks like a little laser probe, and it's superheated at the end. And what it does is it actually cauterizes the hemorrhoid on the inside above what's called the anal verge. The anal verge is where the internal and external meet. Above the anal verge, you don't have any nerve endings. So if I were to take that same probe and put it on the outside of your rectum, you would never come back and see me again. But if it's on the inside of the rectum, you will come back and see me again because it doesn't hurt. So typically that's effective about 70% of the time at shrinking the hemorrhoids, and that causes you, of course, to have less and less pain when you go to the bathroom. Over time, you hope that they scar down. Many times it takes more than one treatment, but not always.
Well, I appreciate you taking the time, Rob, to sit with me this morning. I would like to come back and show a colonoscopy.
You know what would be a great idea?
What?
Is if we get consent from one of the patients, actually show them having a colonoscopy. Of course, not the up close, but just show the process so people won't be afraid of having colonoscopies anymore. They'll understand that they're completely asleep and sedated. Soft music playing in the background. It's like going to the spa.
Maybe we'll show mine. I'm probably due for.
That's fair. You can show mine. That's fine too. Oh, Margaret's maybe having one, so we can show her.
Where?
She's
She'll appreciate
having one
that.
today, next Wednesday.
All right, I'll be back next Wednesday.